Dr. Kassianos, thank you once again for obviously joining us today. Moving on from your fascinating career and background, we are obviously going to discuss the topic of immunisation in a little bit more detail. Now, we're at a real turning point at the moment for the COVID-19 journey, and many of those listening today may have already been called for their vaccines. So the first kind of perspective we'd like from you is, understanding as part of your role as immunisation lead, is there work that goes into planning for potential pandemics such as this?
Very much so, and we thought we were prepared for a pandemic, but we were preparing for a pandemic with influenza that we knew very well, and suddenly we were faced with a virus that we didn't know at all. And as you know, immediately we started developing vaccines and so on back in February last year. But to get to the point of vaccinating the way we're vaccinating now, it really took a long time and a lot of meetings that lasted from August to October. Every day, more or less, we had meetings with the Department of Health and so on, trying to design how we're going to vaccinate the nation, depending on which vaccine we get. And we were getting information as to the vaccines are going to be different. They may require different temperatures and so on. Is it going to be mass vaccination? Is it going to be in car packs? Is it going to be where? Everything was designed. By the end of October, we were ready. On the 2nd of December, the first vaccine got its license. And on the 6 days later, we were actually injecting the very first patient with that vaccine. And as you know, today, it's running extremely smoothly. By today, we have vaccinated 18 million people. That is actually a great achievement for the UK. And we could only have done that with the preparation we did in the months up to the license of the vaccine.
Great, and really insightful to hear how much work goes into that prior to our knowledge as well. Many people have drawn comparisons between COVID-19 and influenza, and you obviously just touched on the idea of influenza there. How would you say COVID-19 and influenza, in comparison to each other? Could you tell us a little bit more about their comparison, and how does COVID-19 compare with other viruses you've also dealt with before?
Well, COVID-19 is one of 7 coronaviruses, of which the 3 are the ones that we fear. There were the SARS-1 we had before, then it was the MERS, and now we have got SARS-2. But we have got another 4 that are not really causing us a big problem. It can be a cold or a little bit more than that during the winter, nothing more than that. But this virus we have, SARS-CoV-2 now, is one that is really extremely well transmissible. The R number, the reproductive number, is between 1 to 4, while influenza is 0.01 to 0.05. You can see how much more transmissible this virus is. Now, the symptoms of influenza, if you go to the office in the morning and you start feeling unwell, by the evening you are in bed. With the coronavirus, it's a much slower affair with the symptoms to actually develop. And that really differentiates the 2 quite well. And of course, coronavirus is causing us so many more symptoms that we never got with influenza, but they're here. And what's more, they go on to continue in about 1 to 2 out of 10 will actually continue for more than 4 weeks. The long COVID and so on. So it's quite different than influenza. I wish it was an influenza virus. We will cope so much better with it. This one is different, and therefore we needed to take different action against it.
Now, obviously, we have PPE that's been introduced for quite a while now that we've all well adjusted to, at least. But people have noted less cases of influenza, for example. Do you think the PPE is sort of bringing that down as well, as when we look holistically at how other viruses and other illnesses are in our community right now?
Well, there are 2 things why we have not seen influenza this year. One is that we have vaccinated so many more people this year. In fact, we have given 2.5 million more doses this year than the year before. And we achieve a vaccination rate of the 65 and over 81%. That is actually an amazing achievement. So that has helped for influenza. But influenza, RSV, and other respiratory viruses, they have all been really very, very low and probably not so much circulation because of all the measures we have taken, the lockdown, washing hands, social and physical distancing, and so on. All that has actually helped really reduce the circulation of the respiratory viruses. Not only that, but we saw a reduction on norovirus. Why? Because we're washing our hands. We saw a reduction in measles, with chickenpox, all these diseases. They were not circulating because we were all really in our homes, shielding to a degree, and going out only really to do our shopping. So that has helped keep influenza down. The same happened in the Southern Hemisphere, and the same happened in the whole North Hemisphere. The problem we are facing now is this, that every year we get our vaccine, but the influenza viruses circulate and we get boosting. By coming in contact with the virus, we don't get any symptoms because we have been vaccinated, but we get that boosting. Now that's very important, but we're going into the next season in September without having had that boosting. So my plea to everybody, come September, please go and get your influenza vaccine. It is even more important than the previous year, because if COVID was to continue, and we think it's going to continue, having COVID and influenza together, you're in a much worse situation than if you had just one of these two on its own.
Great. Thank you for your valuable insights on that. It's something definitely to consider. So we've seen a huge effort by the government, at least talking internally about the UK government, to vaccinate as many people as possible. But what are some of the challenges in achieving this? And could you share maybe some of the immunisation strategy that might go on behind the scenes as well?
Well, it is very important that we actually get people to come and get vaccinated. The vaccination here in the UK is not mandatory. It's if you want to, you get vaccinated. If you don't want to, you are not vaccinated. And therefore, for you to come to us to get vaccinated, you have to trust us. And trust is most important for any vaccination campaign. The foundation of any vaccination campaign is the government. And we have in the UK a government that is very much committed in preventing disease by vaccination. Then is primary care, because that's where the vaccination really takes place. And when I say primary care, I don't mean just GPs, I mean nurses, pharmacists, physiotherapists, everybody, because we all advise patients. And today we all actually vaccinate patients. And the third foundation is our patients. And the patients must be able to trust us so that they can actually come forward and vaccinate. So if we can actually get the trust of patients, we achieve high vaccination rates.
Great. So you've obviously led on various other immunisation programs in the past. How would you say this immunisation for COVID-19 differs to others you've worked on before?
The biggest difference is it is based on mass vaccination. Now, we have done, to a small degree, mass vaccinations with influenza when we open our doors on Saturday, when GP practices were not working, but we open our doors and we vaccinate 300, 400, 500 patients in one day. So we had a degree of experience about mass vaccination. But with COVID this year, mass vaccination is the norm. And it maybe is going to continue the norm how we vaccinate. And when we were designing the vaccination campaign back in August to October, it was always going to be based on mass vaccination. And that's exactly what we do. Now, we went into car parks, we went into gazebos, we did all those things. We found out the pros and cons, but now we're establishing mass vaccination in solid buildings where they can actually stay, because we're going to continue vaccinating for a very long time. Come September, it is possible we will be giving boosters for COVID, and at the same time, we will be vaccinating against influenza.
Great. Now, for those who are interested in the behavior of the vaccine, I don't personally have a medical background. Could you describe maybe for us the mechanism in which the vaccine works and how the body responds to it and how it really protects us from the virus?
Yes, we have to go back to the virus. The virus attacks the body, and what it tries to find is the ACE2 receptors on the surface of our cells. And once it finds that ACE2 receptor with its spike protein, it locks onto that receptor. Once it does that, it gets entry into our cell. And the only thing then it does is to multiply itself, because that's why it lives, is to multiply. It instructs our cells to produce babies of the virus. Thousands and thousands are thrown out all the time. And of course, that's where the genetics go a little bit wrong and you get those mutations. And if it's a mutation, if a mutation is an advantage to the virus, genetically, then it will actually stay. Otherwise, they're lost. And we get a lot of those mutations. So if you're going to produce a vaccine, you've got to produce a vaccine that actually stops that virus getting entry into our cells. And what we did was to actually get that spike protein and produce vaccines against the spike protein. But of course, you have to get that spike protein to the immune system. And the way you do it, you have a messenger, a vector. In the case of Pfizer, for example, or Moderna, you've got the messenger RNA that we have formulated. And to that, we attach the spike protein, and it takes it from our arm to our immune system. The immune system recognizes that as something to really produce antibodies. Not only that, but also remember it in case it comes back later on. In the case of AstraZeneca, they use a virus which is totally harmless for us, but it causes cold in chimpanzees. And what's more, they have removed from the virus its ability to multiply. It cannot multiply, but it can ferry the spike protein to our immune system. So whatever we do is just getting that spike system into our system to produce the immunity.
Great. Thank you for that really comprehensive breakdown. I think a lot of people will appreciate that. So a small minority of people have been a little bit skeptical about the fast-track nature of the vaccine, and people have questioned this across the sort of dialogue around COVID-19. Do you maybe have an argument that could ease their concerns a little bit in this area?
Well, they are worried because normally with other vaccines, you take 2, 3, 4 years to formulate your vaccine. And then you do the preliminary testing on animals. Then you design your phase 1 on just a few volunteers. Then you design your phase 2 on a few hundred volunteers. And then you come into the phase 3, which is the large population, 20, 30, 40,000 people. And that takes you years to actually accomplish. But this time, we were ready for the coronavirus. Why? Because Ebola has forced us to think of ways to deliver something that the body will create immunity. And therefore, the messenger RNA, for example, was ready. The adenovirus was actually ready. As soon as in February, a year ago, the Chinese released the genome sequencing of the virus, that same night, nobody slept. Everybody started to incorporate it in the vaccine, which was actually ready. And then the phase 1 and 2 were done together quickly. And at the same time, they got ready for phase 3, and they were ready to do it in the UK, in South Africa, in the United States, in Brazil, for example, I'm talking about the AstraZeneca, for example, now. And therefore, all these phases were more or less going at the same time, moving forward. And that allowed us within months to have a vaccine ready. We started in February, and the MHRA by the 2nd of December had actually licensed, given emergency license for one of the vaccines, the very first one we had. That is an achievement. There was nothing there that was shortcut. Everything was done according to the book. but it was done in a very fast way. And the MHRA, when they got the information, they were not sleeping at night. They were working day and night, all the committees, to actually do it. I can give you an example. I was one of the 3 reviewers of one of the important papers that went in an important publication here in the UK for one of the vaccines. Normally, I'll be given about a week to 10 days to review a paper. Well, I was given it in the afternoon, and by midnight, I had to send it back. I didn't do anything else. I didn't have dinner. I worked on it and worked on it to get it ready. That's how we managed to actually get the vaccines to the arm of our patients so quickly. And they are very, very successful vaccines. And I'm so pleased because we managed in such a short time to bring forward successful vaccines and vaccinate 18 million by today in the UK.
Well, thank you. I think people really do forget the sort of global collaboration and hard work that goes on to make this happen. So thank you for allowing us to acknowledge that. So really circling back to the idea of the material that's out there for people to understand the vaccine at the moment. Social media has obviously been fueling the idea of fake news and some speculation around the timeline of the vaccine and how it works. And I think there have been a few sort of misleading associations between infertility concerns and women of childbearing age and pregnant women taking the vaccine. What advice would you give to those people? And is there anywhere we can find sort of informed evidence-based information out there?
Well, there is nothing in the vaccines we have today in the UK that has anything to do with fertility. There is nothing there to affect fertility. So fertility is not affected. In animal models that we have, there was no problem with pregnancy as well. Although for pregnant women, we really do a different consultation than for anybody else. So that is not a problem. If one wants to get information, then you can actually search and always put official advice from the government about COVID vaccination. And the first thing you're going to get is the NHS website for people, for the population. And the second one you're going to get, it will be actually for the healthcare professionals. So there is very good advice there to take, but don't take any advice that comes to you about chipping the vaccines so that the government knows where you are and things like that. You cannot, this is serious. We're in the midst of a pandemic. It is a virus that disables us, that kills so many in the population. We really need to vaccinate you as fast as we can so that we can actually contain the virus and then see how we can get out of this pandemic.
Great, I think that's very important. So I think we touched on earlier the idea around the fast track nature, and you confirmed that it wasn't really a fast track nature because the work had been done previously. But for you to be able sort of to tell us how the vaccines happened without compromising safety and how these were developed in that timeline, could you tell us a little bit more about that?
Well, what happened is that back in February, the scientists were waiting for the genome sequencing to be released by China. As soon as they got that, they started incorporating in their vaccines and trying the vaccines, first really animal studies, then on volunteers and so on. But at the same time, around the world, other laboratories were actually trying different ways to formulate the vaccine. And we have got vaccines that they take the whole virus, they attenuate it, or they killed it, and so on. So the two vaccines we have in the UK is not the only way we're going to actually fight this virus. But for the time being, what we have in the UK is two very successful vaccines that have actually proved even better than during their studies, their trials. And that is actually very important because during the trials, we try to really calculate the efficacy of the vaccine, and it's all very controlled. For example, if you take the Pfizer vaccine, it was controlled that 62 cases of COVID in the study, it could be in placebo or in the real vaccine, then you give us the first information you have, preliminary information. And when you hit 94 cases of COVID in the study, then you can stop and give us your results. In fact, they hit 164 at the point where they stopped because they allowed more cases to happen. But of course, there were nearly all of them in placebo patients. So at that point, they released the information. You see that every step was actually very much controlled and very safe because they were doing it the way we would normally do it, but in a much faster way, because out there was a lot of virus and people were falling ill. While if you do a study where you don't have much of virus circulating, it's going to take you much longer.
Great, thank you for expanding on that point, really appreciate that. So there has been some debate within the scientific community around the gap between the 2 doses of the vaccine, and I think a lot of people listening today will have that same query. What are your views on this, and is there new and emerging data and evidence around how this gap works, and do you think as the vaccination delivery scheme goes on it will adjust and this will be changed?
Yes, a lot of discussion has taken place because other countries have not adopted the idea of not giving the second dose at the time when the vaccine gave it during the trial. If we take the Pfizer vaccine, we decided not to give it at 3 weeks. In fact, on the 22nd of December, I was given my first dose of Pfizer, and they gave me an appointment for 3 weeks, and I said, can you please allow me 8 weeks or more than that? And they did, and I got it at 8 weeks. Why? Because the JCVI was thinking this way, that in immunology, when you give when you're a manufacturer, you have to decide when, if you need 2 doses, when is your second dose to be given? What is the earliest time you can give it? And in the Pfizer vaccine, it's 3 weeks. In the AstraZeneca, it's 4 weeks. That's the earliest. But what we know in immunology, when you give the first dose in a disease that your patients have not come in contact with before, you prime them. And if you allow longer time before you give the second dose, then the immune system really gets the memory well done. It creates the antibodies and is ready. And when you give the second dose, then immediately the body answers with more antibodies. It kicks in the memory cells that remember that spike protein, and they produce more antibodies against it, and you get a long-term immunity. There are 2 vaccines that we don't do that. And anybody who is in vaccinology and is watching us now, and you want to know which ones they are, it is the inactivated cholera vaccine and the oral live typhoid vaccine. With those 2, if you miss the time you were giving them, you go back and repeat it. With all the other vaccines, you never give the same dose that you missed. You just give it when your patient comes back. In fact, it's much better to give it longer time than to give it on time. Here, we needed to protect the population as fast as we could. By giving 2 doses, we were depriving half the people of the first dose. And the first dose of any of the vaccines we used, it was more than 50% effective. The WHO told us that to have a good COVID vaccine, it's got to be 50% or more effective. All of them were more than 50% effective. Therefore, 1 dose to 20 million, and then we can start giving the second dose as we go, plus vaccinating more people. It has proved to be the correct thing to do, and I wish other countries did the same, because double the number of people would have been vaccinated today in the world.
Great, thank you for sharing that. And I think a lot of people will be feeling a lot more calm and happy to hear those points from you. So just back to the idea of the vaccination, you mentioned how other countries are doing this, and there's obviously differing sort of national context to the vaccine rollout. But the UK supports the COVAX facility, which was established by the World Health Organization to guarantee the equitable distribution of COVID-19 vaccines. Why would you say this is so important from your perspective?
COVAX is there to help the countries that cannot really afford so much the vaccines. The UK has contributed more than £500 million to COVAX. It's one of the largest contributors, in fact, to COVAX. And what's more, we have already purchased 3 times the number of vaccines we need. And what we're going to do is that once we vaccinate the nation, then the rest of the vaccines will go to nations that cannot afford the vaccines. What's more, the UK is the only country that found a manufacturer to work with a vaccine created in the UK, that the manufacturer undertook to put the vaccine on the market at cost price. That's what AstraZeneca has done. It's not earning any money whatsoever, it's cost price. But if you're getting your AstraZeneca for £2-3 and you're getting your Pfizer for £15 and your Moderna for £25, not many countries will be able to afford the difference in those prices. So we're hoping that more people will go for AstraZeneca in the developing world so that we can actually purchase a lot more of the vaccine with the money COVAX actually has. Now, this disease is global. If we think that by vaccinating our population in the UK, we have done a good job, we haven't, because we travel, they travel, we're going to import it back in the UK, we're going to have the same problem. So we need to work with every single country abroad so that the whole population on this globe is offered the vaccine and accepts the vaccine. Only then we'll be able to contain this pandemic.
Great, thank you for your very valuable insights on immunisation. I'm going to hand over to the Cyprus Medical Society to discuss the impact of COVID-19. Thank you, George.
Thank you, Dr. Kassianos. That's been really very insightful information, and I think the way you describe it, I think is simple for everyone to understand. I had a few questions on the impact of COVID, but I feel quite obliged to ask you a couple of more questions that people are asking as well on our Facebook group, which I think actually are very valid and very, very good questions. And perhaps I will cut down a bit of some of my other questions later on. Someone is asking, I've had the vaccine and I'm breastfeeding. Will my baby create his own immunity, or will he only have immunity while I breastfeed and passing on my antibodies while I'm breastfeeding?
The official
I think that's the case with influenza, right?
With generally any disease, a mother usually passes antibodies to the baby. That's why, for example, we offer the pertussis whooping cough vaccine to the mother, the influenza vaccine to the mother, because then they pass the immunity to their babies. At the moment, we don't have information about the passage of antibodies in the milk to the baby. Whether you look at the green book of the government or the information that has been sent to healthcare professionals, everywhere you see the same thing, that we don't know whether the antibodies are actually passed. My guess is that they are. But the important thing is to protect the mother. That is extremely important. If you protect the mother, you protect the baby.
Fair enough. Thank you. Sorry, Dr. Kassianos, did you want to add something else?
No, that's fine.
No, okay. And one other question, which I think concerns healthcare professionals, because a lot of us have had COVID last year and so on, and a lot of us have had one dose of the vaccine and waiting for the next one. My friend Lynn is asking if you already have antibodies to COVID-19. There is research showing you only need one dose. Is that right?
Well, I have put this to Public Health England that in order to vaccinate more people, what about offering only one dose to those who have had COVID, but proven COVID? Why? Because they have been primed. The first dose only primes you. The second dose is the one that is going to give you the long-term immunity and the boosting. And from then on, you never have 2 doses again. You only have 1 dose. And therefore, the questioner is correct that 1 dose should do, but at the moment, the policy in the UK is to give them 2 doses, but towards 12 weeks apart.
Understood. And you mentioned earlier that it's very important that we need to get the trust of the patients and of our community. So is there any evidence that you would like to share with us in terms of the effectiveness, not the efficacy, the effectiveness of the vaccine in the community, given the experience that we've had for the next, from the last couple of months that is being rolled out, both in the UK and also internationally?
For the benefit of everybody, efficacy of the vaccine is in the clinical trials that we control. Effectiveness of the vaccine is when we put the vaccine in the population and we see how it performs. And the two are not the same. Where the efficacy of the vaccine in the trials may be 50, 60%, when you give it to the population, you may find this 80, 90%. And we are finding that now with AstraZeneca. That is a lot more than what the basic trial has actually shown. And therefore, what we need to do is to keep on vaccinating and to keep on getting information about the vaccines. And the effectiveness of the vaccine today, we actually find that it's towards 80 to 90% and above of both vaccines. And sometimes the Pfizer is better, sometimes AstraZeneca is better in numbers. That is to say 95 or 85 or the other way around. As you know, in Scotland, in hospitalizations, the AstraZeneca actually stopped 95% of admissions to hospital, while the Pfizer actually stopped 85. But in other studies, it's the other way around. So basically, both vaccines given to the population are very effective.
Okay, so there's definitely clear evidence that this is definitely working. It is said that our Cypriot community has been adversely affected by this pandemic, perhaps proportionally more than the general UK population. Is that right? Would you agree with that? And is there any reason why this may have happened?
The BME, yeah. The Black, Asian, and minority ethnic communities have been hit hard. It's very difficult to be able to say exactly why, but you have to think that there are other factors there that are very, very important. You have got houses where you have got 2-3 generations. If you have got a lot of people living within one home, you're actually going to get a lot more of the infection. And the state of health of people, chronic disease, obesity, deprivation are also very important. So for the BAME community, we have done studies, and they're showing that there is a difference in them. And at the moment, every area where we have got BAME communities, we are trying very hard to work with the people in the community so that we can get the trust of them. Because if they come forward and get vaccinated, then they will have the same immunity like everybody else. But we need to actually get that vaccine to their arms. And as you know, more BAME people don't have the vaccine than with other, say, Caucasians, British people. So we need to get the trust of the Black, Asian, and minority ethnic communities, and we need to get them vaccinated. And once they're vaccinated, they will find that they will be healthier, less of them will be admitted to hospital, less of them will be dying, and so on.
Understood. And Dr. Kassianos, vaccines and new strains, what's your take on that? Do we need we need to have different vaccines every year because of new strains coming the previous season, like influenza?
we know from influenza that the virus mutates, and one of the biggest problems we have in influenza is the one with one strain that is in our vaccine, the AH3N2. And when the WHO asked the manufacturers in February to produce vaccines with these strains, the AH3N2 by September could actually mutate and be quite a different virus, and not always exactly as it is in the vaccine. Now, that's a slow mutation. The COVID virus actually mutates much faster. It produces those babies in our cells in thousands and thousands, and there are a lot of mutations. And if there is an advantage for evolution in any of those mutations, then that mutation will stay. For example, the E484K is a mutation that we worry about now, because every time it goes on to a variant and joins the variant becomes worse than before. We're going to have variants, and already we're working on vaccines for September, for the fall, for the autumn, because we may have to be boosting the population again with more vaccinations. But we need to get the vaccines we have now in everybody's arm so that they are ready for revaccination, rather than to be vaccinated for the first time then. Why? Because the B117 that we have in the UK circulating now, it's very much one that the vaccines do prevent. And that's very important.
Thank you. I was about to ask you now whether the existing strains or variants that we've got now are covered by the existing vaccines. That's great that you've clarified that.